Thank you, everyone who's tuning in. Good evening, and I appreciate you joining us. Thanks also to the JCC for hosting us in this nice space. Today, we're going to talk about how common heart disease is in this country, and it is very common. We're going to define heart disease a little bit more specifically, and we're going to talk a lot about screening, how to identify if you or someone that you know might have early heart disease or risk factors that might promote heart disease. And we're going to spend a big portion of our time together talking about prevention and the importance of lifestyle in preventing heart problems. So, heart disease is indeed the most common cause of death in this country. About 18 million people have coronary artery disease, and one death every 36 seconds is attributable to this problem. So basically, 1 out of 4 people will ultimately die of heart disease. Over the age of 40, the risk of developing heart disease is nearly 50% in men and 32% in women. All of these statistics do apply to most racial and ethnic groups as well. Since the 80s, there have been more cardiovascular deaths in women than in men. And unfortunately, about 80% of people who have a sudden cardiac death had no previous symptoms. Younger people can be affected as well. So these are sobering statistics, and we'll talk a little bit more about prevention later. When we talk about heart disease, we're primarily talking about problems with the arteries of the heart, or really the plumbing. But people can also have problems with the valves inside the heart or with the electrical system of the heart, and that's called arrhythmia. The heart muscle can become weak, and that usually has to do with one of the above 3 mentioned problems. So just a little schematic here. Today we're going to talk about heart disease in the context of coronary artery disease. So the coronary arteries feed the heart muscle. They run over the surface of the heart, and as mentioned, are really the plumbing system. What are some symptoms that we need to watch out for when we're concerned that someone might be having a heart problem? Well, classically, we're taught that central chest pressure, maybe with radiation to the arm, made worse with exercise, and that is what we call classic angina. But there can be a lot of other symptoms of coronary artery problems, such as shortness of breath alone, jaw, neck, arm, or back pain alone without any chest discomfort, nausea, vomiting, unusual sweating, or more vague symptoms such as new fatigue or feeling lightheaded. Of course, these symptoms can also be very general, so it doesn't mean that if you are fatigued, you have heart problems. But if things seem different for you, it's definitely worth talking to your physician. Going to show a little video, not made by me, but it's a schematic of what's happening inside a heart artery when somebody has an acute heart attack. So here we're going to zoom in on the left anterior descending artery, which comes down the front of the heart, and we're going to look inside where you'll see plaque buildup. So plaque is made up of cholesterol and a lot of inflammatory cells like certain kinds of white blood cells, and sometimes that plaque ruptures open, as you can see here, and the body doesn't like that. And it says, this is something bad, we need to clot it off, we need to wall it off. But of course, oh yeah, I can do this. Going back to, hang on one second, PowerPoint. Perfect. A clot in an artery is like putting a dam in a river. So that was just a little bit of kind of what's going on inside the arteries during a heart attack. So what makes this plaque be there in the first place, and what causes the plaque to rupture and cause a heart attack? Well, inflammation has a lot to do with this, because a lot of people have high cholesterol or don't eat well, but they don't necessarily form plaque. And sometimes that plaque becomes unstable and opens up like a blister, as we saw, if there's a triggering event, such as a sudden rise in blood pressure or some sort of other toxin like smoking a cigarette or doing cocaine, something happens where the vessel spasms or the plaque ruptures, and again, then we're in that situation that we saw in the cartoon. Significant mental or physical stress and an increase in stress hormones can trigger unstable plaque as well. So lots of people have heart disease. Sudden heart attacks and sudden death are unfortunately very common. What can we do? And that's really the meat of tonight's lecture. I spend a lot of time helping people and taking care of people after they've had cardiac events, but my preferred thing is to help people not have cardiac events in the first place. And of course, it is still true that an ounce of prevention is worth a pound of cure. So what do we do? What can we do? Well, we've known for decades that certain, what we call cardiac risk factors, and that's a general term, and I'll be more specific. If people have these things, they are more likely to develop plaque inside their heart at increased risk of heart attack and stroke. So high blood pressure, high cholesterol, diabetes or prediabetes, smoking cigarettes, having a genetic predisposition in your family, being over 55 years of age for women and 45 for men, being overweight, not exercising, and having kidney disease. So these are what we call classic cardiac risk factors. So if you have one or more of these, we would want to be even more careful about how we're treating those risk factors and other things about your medical history. We, over the past several years, have started to also understand that there are other links to heart disease. So vitamin D is an interesting physiological parameter, and we know that a lot of people with heart problems do have low vitamin D, but it's not completely clear from randomized trials that simply raising vitamin D through supplementation reduces the risk. It's probably more that low vitamin D is a marker of other poor health habits. People who have obstructive sleep apnea or other kinds of sleep disordered breathing, and we'll talk about sleep a little bit later, have a higher risk of heart problems. And then folks who have other vascular issues, what we call vasospastic problems like migraine headaches or Raynaud's disease, may be at increased risk of heart artery problems. This is not to say that if you have migraine headaches, you are automatically going to have a heart attack. We're just starting to understand these links. Autoimmune diseases such as lupus or ulcerative colitis or rheumatoid arthritis can be problematic, largely because those are very inflammatory in the body, and we talked about how inflammation, it promotes plaque and promotes plaque rupture. Chronic infections such as HIV, history of radiation to the chest, largely done for certain cancer treatments, and then certain chemotherapies can, in the long run, cause heart problems. Gout, because it's an inflammatory situation. And then for my female patients, I try to always remember to ask them about if they've had any pregnancies and what their pregnancies were like, because women who develop high blood pressure or more seriously preeclampsia or diabetes during pregnancy are definitely at risk of developing those problems later in life, even if those problems resolve in the immediate postpartum period. Polycystic ovarian disease is a somewhat high insulin state, so there's insulin resistance, and that can also be related to heart disease. So lots of things about people can raise some red flags, like, oh, you had high blood pressure during pregnancy, and now your blood sugar's a little bit abnormal. We're gonna try to look more carefully at that person and maybe do some additional screening, which we'll talk about here. So there are some tests we can do that are non-invasive that help us understand if someone has started to build up any plaque in their system, and that includes coronary artery calcium scoring, also known as a heart scan, looking at their cholesterol in a more advanced way beyond simply triglycerides, LDL, and HDL, and that includes things like a lipoprotein little a. LP little a is a small particle that's attached to LDL particles, which is a type of cholesterol, and it actually promotes that plaque. So if someone has a high lipoprotein little a, they're more likely to get plaque in their arteries. And then we can also look at how much inflammation is in somebody's body. So there's a lab test, a blood test, called high sensitivity C-reactive protein. And that is going to be elevated if someone has the flu, if someone has COVID, if someone has cancer. So it's not specific, but we know from clinical trials that even in people who are healthy and have no signs of infection or autoimmune disease, if they have higher inflammation in their body, they're at higher risk of heart disease. So sometimes we add that on to, for example, cholesterol testing. And then we can also look at people's carotid arteries in the neck to see if there's any plaque there, because it's all one big vascular system. So if someone's got plaque in the arteries of their neck, they may have plaque in the arteries of their brain, leading to stroke, or plaque in the arteries of their heart. This is a picture of a CAT scan of somebody's chest. We're looking up at the patient from their feet. So this is the heart. And this white material here, you can see the arrow on the screen, should not be there. That is plaque that is starting to develop in the left main coronary artery and the LAD in the left circumflex. And we may see this in someone who's never had chest pain, who's never had an abnormal stress test, who's never had a stent, and we say, okay, this person already has plaque and we need to kind of change how we think and change what we do. So this is a screening test. If someone's actively having symptoms, we're not gonna do this test. We're gonna probably do something like a stress test or a cardiac cath. This is a picture of how we take ultrasounds of the carotid artery, and this is normal actually. So this is an ultrasound picture. Where my arrow is inside this neck vessel here, and the lining of the vessel is nice and smooth, it's not thick, and there's no plaque there, so this is normal. Whoop, I went backwards. Okay, so everyone's gonna run out and get CRP testing and a heart scan, and we don't need to do that. Some people need to do that, but we need to start with the basics. So all of us should know our numbers, and I'm gonna review that in a moment. And all of us should understand our medical history, and hopefully your doctors are asking about your medical history, pregnancy history, family history. And then folks who have a few risk factors, so maybe they're 60 and they have borderline diabetes and they still smoke, and we're trying to decide whether we should put them on a cholesterol medicine, those people perhaps should get the carotid ultrasound test or the other lab tests or the heart scan. So here are the key numbers. What is normal? Well, normal blood pressure is 120/80 or less. Normal LDL cholesterol, so that's the bad cholesterol, quote unquote, should be less than 100. So interestingly, babies are born, and I don't know who decided to test cholesterol in babies, but most babies are born with an LDL cholesterol of about 40. I don't know many adults with an LDL cholesterol of 40 not on medication, so kind of all goes downhill, I guess, from birth. HDL cholesterol, which is the good stuff. So LDL is the bad stuff, and HDL is the good cholesterol. I remember that H, you want it higher. Ideally would be greater than 50 in women and greater than 40 in men. Triglycerides, which are another cholesterol parameter, should be less than 150. And body mass index, which is your weight in kilograms divided by your height in meters squared, should be in this range right here to be considered normal weight. BMI is not a perfect screening tool because people who are perhaps more muscular but have less body fat might have a BMI that would put them into an overweight category. So I understand that this is not a perfect tool, but it's a good place to start. Waist circumference right at the at the belly button should be less than 35 inches in female or 40 in male. And people who have diabetes should have their overall blood sugar control, which is this hemoglobin A1C number, less than 7%. So switching gears a little bit here, we kind of know our goals, we know where our cholesterol should be and where our blood pressure should be. So how do we get there? And how do we ultimately prevent things like heart attacks and stroke? Well, it's actually pretty simple. It's not that glamorous or fancy or brand new, but really nutrition and exercise and good quality sleep and stress management are the most important things that we can do, not only for heart disease, but to try to reduce the impact of other chronic diseases as well. So I'm not a nutritionist. I spend a lot of time talking about eating patterns, but I try to keep it very simple. So I like to start, if someone is interested in kind of what they should eat, with the concept of the Mediterranean diet, largely because this is a diet that is free of processed foods and contains a lot of fruits, vegetables, and good fats. So I think it's a good place to start. And it turns out that fruits and vegetables are very good to eat. We can argue about dairy, we can argue about gluten, we can argue about whether someone should be meat-free or only eat fish. But I don't think we need to argue about the fact that fruits and vegetables are good for us. And this is a fairly old study, but still very relevant, showing that basically the more servings of vegetables and fruits you eat in a day, which is along this axis, the risk of your heart disease decreases. So your grandma was right, eat your fruits and vegetables. And when I'm talking about eating patterns and nutrition, I like to focus on all the amazing things that we can eat. Like, wow, there are 8 different kinds of apples in the grocery store right now, or it's gonna be peach season soon, or I've never tried this kind of kale. And I think that once we focus on all the things we can eat, like, oh, it turns out avocados are really good for you and nuts are really good for you, instead of, I can't have that cookie, I can't have that ice cream, and I can't have that hamburger. So I like to sort of say, you can, but you should just have more of the other stuff. So trying to change the paradigm a little bit. Keep doing that. As mentioned, vegetables and fruit. Think about every time you're gonna have a snack or have a meal, it should contain a vegetable or a fruit. High fiber, unprocessed foods, good fats, which we'll talk about in a moment, and high quality protein. So again, basically this means unprocessed foods. As one of my partners likes to say, anything that comes in a box in a bag will put you in one. So a little dramatic, but I think kind of a good mantra to think about. So back in the 80s, if I recall, there was this big low-fat trend for a long time. So people were eating no-fat potato chips, and I ate a lot of bagels without cream cheese because the cream cheese was bad. So it's not fat that's the problem, but really more saturated fat, fat in processed food, trans fats. That's what we're trying to minimize. But fats that come from plants, like nuts and olive oil and avocados, or fish, such as salmon, are actually really, really good for us and can help with feeling satisfied because fat takes longer to digest. Not only quality of what you're eating, but quantity of what you're eating is also very important. So yes, almonds are good for you, but a bag of almonds in one sitting is too much in terms of overall calories. So kind of thinking about portions as well. But again, keeping it simple. Looking at your dinner plate and saying, okay, I'm gonna have a lot of vegetables here, and maybe even extend those mixed vegetables out on the plate. Little bit of protein, little bit of starch, but that's a sweet potato, so that's also a vegetable. Some fruit. So just kind of visualizing your plate having meat as a condiment and mostly vegetables. So we get a lot of questions about supplements and what's good for your heart, and I heard that this was good to take and all of this. And I'm not categorically opposed to supplements, but definitely a varied diet, which we just talked about, is really the most important baseline for people. Vitamin D, as mentioned, a little controversial. I think most of us probably don't get as much natural vitamin D these days because we wear sunscreen and we work inside a lot. So I don't recommend that people take massive amounts of vitamin D, but perhaps a baseline level could be helpful. You could talk to your primary care about that. Especially for women who may be worried about bone density, we've backed away from the really high doses of supplemental calcium, and we now encourage people, men and women, to get most of their calcium intake from food, whether that's low-fat dairy products or fish or certain greens. But if someone has osteoporosis, that might be a different story. But mega doses of calcium, remember the little Viactive chews, I used to eat those all the time, not recommended. In fact, there may be some link with a lot of calcium supplementation and then that calcification in the heart. It's a little hard to sort out though. Specifically, things that we used to think were good are really not good. So vitamin E, tons and tons of vitamin C, beta carotene, folate, no clear benefit. I just want to point out that obviously if a woman is trying to get pregnant or is pregnant, folate is important in terms of supplementation. So pillar number 1, nutrition. Pillar number 2, exercise. So really we all need to move, and whatever way works with your life, works with your interests, works with your schedule. You know, if you're like, oh, I'm so busy, I don't have time to exercise today, you probably have time to go for a 10-minute walk after dinner. And some is better than none, so the 10-minute walk counts. 30 minutes is better than 10 minutes. I have a little caveat here though, because we live in Boulder, we have a lot of really active people, which is fantastic, but there's definitely a sweet spot with exercise, and this is not a talk about endurance athletes, but when I say more is better than less, I don't mean 20 hours a week of training is better than 15 hours a week of training. I'm just talking about these moderate levels of exercise. I'm also a fan of strength training because that helps build lean muscle, which promotes metabolism, and it also helps with bone density down the road. I was an anthropology major in college, so you know, we've come a long way from having to, sorry guys, I'm mouse happy here, having to hunt and gather and survive and spend our entire waking day kind of worrying about food and being active in order to get that food. I mean, food is everywhere now, and we don't have to move that much to get it. So we really need to be as active as possible during our day. I really like this graph because just taking a look at the bottom here, we'll look at this pillar right here. If you walk more than 75 minutes a week, which is not that much. I did the math yesterday in my head and now I'm spacing it out, but basically it's an hour and 15 minutes a week of walking. So if you break that down over 7 days, that's not that much. You can actually add 2.5 years to your life. This is just walking. This isn't like go train for a marathon. So it's just that it's really important. I mean, I can't emphasize that enough. And I like to say to my patients that exercise is the best medicine we have. The third pillar, sleeping well. This is not a sleep lecture. I'm not a sleep doctor. I'm not going to get into details about like, well, what should you do if, but we know that sleep affects not only cardiovascular health, but all aspects of health. And less than about 7 hours a night does increase heart disease risk. People who don't sleep well, they don't sleep with good quality or with good quantity, tend to have gain weight, and basically just not feel good, increased risk of that inflammation, increased risk of depression. So if you feel like you don't sleep well, work with your physician to figure out maybe what's going on. Again, this isn't a sleep lecture, but just to say that sleep is super important for health. And then finally, stress management. And this is easier said than done. I don't mean to stand up here and say, so everybody just relax and do yoga and you'll be fine, because we all have different types of stressors in our life. But it is clear that stress does affect the heart. I mean, the sort of stereotype of the CEO running around his office or her office and going to meetings and drinking, 18 cups of coffee a day and then just dropping dead in the office. I mean, that is grounded in some truth. And heart attacks are less frequent in the summer. It's probably because people are taking some time off. Maybe they're getting outside more to exercise or spending more time with family and friends. And heart attacks are more important based on this little middle graph right here, sort of excess incidence of heart attacks and sudden deaths, where my pointer is. Heart problems or sudden heart problems, what we call acute coronary events, are more common during the morning hours. Waking up, little burst of adrenaline, late to work, fight with somebody, argument, caught in traffic. So again, stress is really important. And trying to manage our stress is really important. There are a lot of different ways to do that. And kind of thinking about it and finding out what might work for you would be great. Personally, a few minutes of meditation daily has dramatically improved my stress level beyond what I thought, so I was pleasantly surprised by that. And that's just a few minutes a day. So inflammation keeps coming back throughout this talk. We talked about the 4 pillars. I just wanted to mention quickly that visiting your dentist, getting your teeth cleaned, getting any sort of gingivitis or periodontal disease taken care of can be really helpful, because again, the inflammation anywhere in your body can affect the heart. Don't need to explain this slide too much, but if you smoke, we can help you quit. So we've spent a lot of time talking about how common heart disease is, what is heart disease, how we can find out if we have heart disease, and what to do. And I'm just going to spend the last few minutes talking about habit formation, and instead of, I'm kind of trying to get away from habit and use the phrase practice pattern, because habit to me has a little bit of a negative connotation, because there are good habits and there are bad habits, and you need to break your bad habit and breaking habits, and it just seems punitive. So I like to kind of think about what we do every day and how we can change some things that we might be doing every way that might not be as good for us to something different. And we do something because we feel better in the short term, and it has long-term benefits. So you're going to feel better if you go for a 10-minute walk after dinner. You're going to start to digest. It's beautiful outside. We live in a great place. And you're going to feel better. We're not asking you to do things that are super painful or super hard, or, and like, if you like avocados, eating guacamole with carrots, that's a really good thing to do. And it's not like you can never have a cookie, but we're trying to have people do things because we know that they're going to feel better short term and long term. So it's all about trying to kind of shift how you think about your daily rhythm, because really most of our day tends to be automatic, right? When we wake up, usually what we eat and kind of what we're thinking, whether or not we exercise, there's a lot of automaticity that we can train. Love that. Personally, I think exercising with people, and now that COVID is receding, we can do more group activities, hiking outside. I find that it helps kind of build that pattern of wanting to exercise because it's also a social thing. And as mentioned, all of this is good for your heart, but it's also good to reduce cancer risk, improve brain function, and reduce the risk of dementia. So these aren't exclusive things. Anything that you do that's good for your heart is going to be good for other parts of your body and other parts of your life. I like this slide because it is a summary of this concept called geographical blue zones. So I don't know if any of you have heard of this, but I've been learning a little bit about it and I find it fascinating. So blue zones are parts of the world, and you see these little blue dots: Loma Linda, California; Nicoya Peninsula, Costa Rica; Sardinia, Italy; Ikaria, Greece; and then Okinawa, Japan. These are places where there's an amazingly high concentration of people who have lived well into their 90s and often greater than 100 years old, and they're really healthy. They're not just old, but they're doing really well. And so there was a National Geographic spread on this a while ago, and I have a link to an article on my last slide about, well, okay, not only are these people living long, but they're living well. What's the secret? And it's not a secret. It's not one specific plant that only grows in that area. It's these 9 habits, I use the word, these 9 practice patterns that most of these people engage in throughout their life, and they end up just living very healthy. So they exercise, they have sort of a purpose in life, they take time to relax every day. The 80% rule has to do with they don't stuff themselves at dinner, they stop when they're about 80% full. So again, not starving themselves, not dieting, but just not eating to excess, eating mostly plants. Alcohol can be controversial, but a lot of these societies drink alcohol in moderation. I don't recommend that people drink alcohol if they go out and start drinking if they don't already drink, but in moderation, it can be helpful. And then things like knowing your people or having a support system or having close friends, that's all of these right here. So again, it's not a secret, but these people are living it. And I just find it a really fascinating concept of blue zones. We talked about exercising and sleeping and all of these things. But for some people, and for a lot of folks that I help take care of, all of those things are important. And then in addition, we need to talk about medications. And that's not a character flaw, that's not a failure, but sometimes we just need another layer to reduce their cardiac risks, such as statin medications, being on blood pressure medications, or medications for diabetes, or potentially being on aspirin. So being on a medication, again, isn't like, oh, well, if I'd only exercised more. No, we want you to do all those other things, and then sometimes we just need a little bit of help as well. So if you do have heart disease, it doesn't mean that, well, now I'm on atorvastatin and I have a stent and all this other stuff doesn't matter. It doesn't matter if I exercise. No, it does, because we don't want you to need another stent or have another heart attack. So keep working on the risk factors and the lifestyle modifications. See your doctor. A lot of our patients end up attending cardiac rehab, which is a really good program to build exercise and confidence. So that is what I have for the formal talk. Here are some resources that I find really helpful for patients about nutrition. The Blue Zone article is linked there. And at this point, I am happy to answer any questions. Thank you so much.
Right. Thank you so much, Dr. Ware. That was really informative. We do have quite a few questions, and we can also, ask folks to go ahead and ask their questions in the chat box there. And while we're answering these, maybe we'll get a few more questions coming in. So the first questions we have: where is the best place to get a heart scan?
So the question is, where is the best place to get a heart scan? And there are a few places in Boulder. Boulder Community Health does heart scans. Front Range Preventative Imaging does heart scans. And I would imagine that any imaging center could do it. Caveat, I have not seen insurance pay for it. So it's usually somewhere between $150 and $200 out of pocket. So that could be a consideration. But those would be my recommendations.
Would you need a referral from your...
Generally, you don't
okay.
for a heart scan. Nope.
Okay, great. So what can we do to prevent inflammation in our body?
Great question. Huge question. What can we do to prevent inflammation? So first thing I would like to say is not all inflammation is bad. If you fall and sprain your ankle and your ankle is swollen and it hurts, that is your body healing it. So not all inflammation is bad. It's more the chronic, ongoing inflammation over months to years that can promote plaque buildup. We saw in that video. So when the lining of the heart vessel becomes inflamed, it's more likely that the cholesterol plaque can get down in there. So it's the chronic inflammation that we are more concerned about. And all of the lifestyle things that we talked about, so eating a diet that's got no processed foods and lots of vegetables, sleeping well, exercising on a regular basis, that all of those things can reduce inflammation in the body. So it's actually the things we talked about tonight.
That would probably be the same answer to this question: what is the best way to lower cholesterol without medication?
Absolutely.
It's all the things that you just said.
Absolutely.
So what exactly is plaque? What is it made of?
Great question. So plaque is actually a very complex process. And it's made up of what we call oxidized LDL particles and other types of cholesterol, and then inflammatory cells. So white blood cells that have sort of started to process the plaque. And I'm not a basic scientist, so there are a lot of people who know a lot more about plaque formation than I do, but there are different phases of plaque formation. So sometimes there's not much plaque there, but it's actually a little bit more unstable because it's more inflamed. And then over time, that plaque kind of settles in and the body walls it off a little bit and becomes a little bit more stable. So it's a good question, and it's primarily made up of, I guess you could say, inflamed cholesterol particles.
Can it ever go away once it's formed?
There have been some ultrasound studies and some angiographic studies, largely in trials involving statins, showing that statin medications, and I'm talking about atorvastatin, rosuvastatin, that class of medications, can regress plaque. It can kind of help the body resorb it and go away. I have a different lens. I have a lot of patients who have a lot of plaque, so I've never seen it go completely away, but it can definitely get better and stabilize. And our goal is to stabilize the plaque that's there. So again, that blister doesn't rupture open. And guess what? Exercise, eating well, sleeping well, and then some medications for sure. Obviously I prescribe a lot of statins, and they are excellent medications. So that would be how to stabilize or potentially regress plaque.
All righty. Is it for sure that I will have heart disease if it's in my immediate family?
It is not for sure. So if, for example, your dad had a heart attack at 70 versus your dad had a heart attack at 35, and your brother had a heart attack at 40, and your sister, so it depends on sort of the severity and the age at onset. So it is not for certain, but if you do have that family history, especially if it's what we call the more aggressive family history, then I would, make sure you know what your cholesterol is, make sure you know what your blood pressure is and your blood sugar is, and then talk to your doctor about, do you need to have any other testing done?
All righty. So that answers this question: how big a role do genetics play in heart disease?
Yeah.
So I think that...
And it's hard to put a percentage on it because it's such a variable thing, but certainly we see with cholesterol specifically that genetics can play a role. I mean, people can eat no saturated fat at all. So, vegan diet, no animal products, they're normal weight, they exercise all the time, and they can have really, really bad cholesterol, and that's largely genetic. So it's hard to put a percentage on it for general purposes.
Right. Can you give strategies to lower LDLs if you cannot take a statin?
Yeah, so as much as possible, reducing saturated fat in the diet. And again, that comes from animals, like high-fat dairy, fatty meats, that butter, that type of thing. So eating very little saturated fat, exercising, being a good weight, all of those things we talked about. And then there are other medications that are non-statins. Zetia is a medication that can lower LDL cholesterol. We have a new class of medications that are actually injected subcutaneously that dramatically lower LDL cholesterol. And then there is a supplement called red yeast rice, which is technically a statin, but it's at very low dose. So those would be some of the first things that we would start with. And there are some older cholesterol medicines as well.
What did you just say? Red yeast?
Red yeast rice. It's an
Red yeast
over-the-counter
rice.
supplement, but technically it contains a very small amount of, I believe it's lovastatin, a lovastatin type molecule. But some people tolerate that better than prescription statins, largely because it's a very, very low dose. And often what I do in my practice is if someone hasn't been able to tolerate statins, but we agree that they would be a really good class of medications for them, we try an alternate statin, or we try the tiniest dose possible a couple of times a week. Because just lowering the LDL some is better than lowering it none. So we have a lot of tricks that we can try.
Excellent. What about coconut oil? What are your thoughts on that?
This is such a good question, and I was researching this several months ago because I was like, oh, well, coconut tastes really good. It's good in a lot of things. It's very satisfying and rich, and it's a plant, but it is a saturated fat. So the data suggests that eating a lot of coconut oil can actually raise your LDL cholesterol. So I would say if you enjoy cooking with coconut oil or eating coconut in various forms, you don't have to eliminate it, but I wouldn't have that be your primary substitute in your overall diet. So yeah, it's a saturated fat.
Right. You may have covered this, but this question is, are there any clinical trials that you know of being done on the keto diet and heart disease?
Keto diet. So
Keto diet, yes.
As I understand it, the keto diet, which is short for ketogenic, is similar to the Atkins diet, which was popular several years ago, and really basically is a diet that's very high in protein and fat and has very little in the way of any form of carbohydrate. So it can help people lose weight. It can help people sort of jumpstart their weight loss because you're basically working on you're using your fat reserves for energy. As a cardiologist, I get a little bit worried about it because it can, if done a certain way, contain a ton of really high saturated fat foods. So I worry a little bit, and I also worry that it may not, and again, I'm not an expert in keto, it may not contain the variety of fruits and vegetables that I think are really important for health. Because if you think about, an apple has not many calories, and it's got water and fiber and phytonutrients and all sorts of things that we can't get in a supplement that is not present in a steak. So you're missing a lot of micronutrients if you kind of really restrict your vegetable matter. So again, I'm not an expert on keto, and maybe there's some subtleties there that I'm missing, but I would say it's helpful for initial weight loss, and then I would encourage people to kind of try to find a balance with adding in some of the other foods and finding it more sustainable. So sustainability is important to me. Like, what are you really gonna do every day?
Excellent. We have this question just came in. Can you do anything to change Lp(a)?
Yes, so that is such a good question. So we talked about some of the more advanced cholesterol tests that we do, and I would look for Lp(a), which is a blood test, in a patient who's relatively young and had a heart event and doesn't have any traditional risk factors. Like, what is going on here? So we can't budge that number that much. Maybe niacin can help it. Statins don't really actually change the Lp(a), but statins will reduce the overall amount of LDL that you have. So really our primary goal in patients who have a high Lp(a) is to treat their LDL cholesterol to as low as possible with statins or other medications. So we can change Lp(a) a little bit, but we don't have like a magic medication at the moment.
Is snoring the same as sleep apnea?
Not necessarily, but snoring can be a sign of sleep apnea. So people can snore and not have sleep apnea. People can have sleep apnea and not snore. But snoring on a regular basis, reports of, oh, she stopped breathing and I had to like nudge her to wake up, and then she started breathing really fast. So disrupted breathing and snoring, especially if accompanied by waking up in the morning with a headache, feeling super tired during the day, falling asleep at a stoplight, and having high blood pressure or heart disease, I would very much get screened for sleep apnea at that time. But a little bit of snoring now and then does not diagnose it.
If you have a high calcium score from a scan, can it be reversed?
It can't go to 0. I mean, I've never seen it. But our goal at that point would be to help to have it not get worse. So some plaque can go away, but probably not all the plaque. Again, this didn't happen overnight. You know, if someone's got a high calcium score, that soft plaque got laid down and then the plaque changed a little bit. We talked about the sort of complex pathogenesis of plaque. So goal is to stabilize. And again, I mean, I have a lot of patients who have a high calcium score, but knock on wood, they've had normal stress tests, they've never needed a stent, they've never had a heart attack. So it doesn't automatically mean that there's going to be a problem, but we just need to be really aggressive about trying to prevent the problem.
What about hormone replacement therapy?
That's a really good question. I have another talk that I give from time to time that's more focused on women and heart disease. So in brief, it is a very controversial topic. So in the cardiology world, we do not actively prescribe HRT to reduce cardiac events. We used to. But then in about the year 2000, a big study came out called the Women's Health Initiative that was sponsored by the NIH. So it's going to be really hard to duplicate it because it was a huge study. And that showed that women who took a specific type of HRT, like higher dose estrogen and then I can't remember which progesterone, but a pretty hefty dose of HRT were at higher risk of things like blood clots and breast cancer and heart attacks, and everyone understandably got super nervous. And then we said, well, then no one can be on HRT, which is not true. So the truth lies somewhere in the middle, because since that study was published 20 plus years ago, we have a lot of different hormone preparations. We know that lower dose is better. We know that probably like a transdermal patch is probably better than oral. And you know, in some women, it's a huge quality of life thing. So I wouldn't want someone to just be suffering with night sweats and mood lability if we could, you know, have them on low dose HRT for a few years. So the party line in cardiology is we don't prescribe it, and we encourage women to get off of it as possible. And in women who've had any sort of blood clots or breast cancer, we absolutely would discourage it. But point being, it's a controversial topic. There's a lot of smaller studies ongoing right now, so hopefully we'll have a more cohesive guideline in a few years. How
exactly do triglycerides affect the heart?
Track what?
How exactly do triglycerides affect the heart?
Oh, yeah, that's a good question. How do triglycerides affect the heart? It's probably not a direct effect, but it's more like the company they keep. So if someone's got high triglycerides, they probably have abnormal glucose metabolism. They may be overweight, which can promote high blood pressure. So it's more about a marker of other factors. And we certainly care about triglycerides and we like them to be as low as possible, but in our world, the LDL is the most important.
Another calcium question. Do calcium supplements from osteoporosis see calcium deposits? Do calcium supplements for osteoporosis calcium deposits in coronary arteries? I think that question is, if you take a lot of calcium supplement, does that result in added calcium buildup?
So there actually is some concern that that may be true. I mentioned kind of halfway through the talk that as a medical community, we no longer recommend supplemental calcium above about 1,000 milligrams a day, and we like people to get most of their calcium from food. The exception is if someone has osteoporosis or osteopenia that's been diagnosed by your medical provider and it's clear that you're at risk of having a fracture, then things may be a little bit different and you may end up needing, more supplemental calcium. But for people who don't have any bone problems, like I don't take calcium anymore. I try to eat a good diet and exercise and do weight-bearing exercise. So I don't want to steer someone the wrong way if their physician has recommended calcium specifically because they have osteoporosis. I think that that's important, but there is some data that, getting up to sort of 1,000 or 1,500 milligrams a day may kind of promote some of this plaque in the heart.
If you're already diagnosed with cardiomyopathy from cancer treatment, is there a possibility of the heart muscle repairing itself?
So the question is about, there are some chemotherapies, especially a lot of chemotherapies that are used for breast cancer that can affect the heart muscle function. So now we're talking more about the pumping function of the heart and not about the arteries of the heart, which we spent most of tonight talking about. So it depends on what the chemotherapy was. So if someone had an adriamycin-based chemotherapy and they end up with heart dysfunction, that actually is unfortunately not usually reversible. And we need to do the best we can with kind of helping protect the heart with certain medications. If someone is on a different class of chemotherapeutics called monoclonal antibodies, like Herceptin, for example, they can have what we call a transient cardiomyopathy, where if we stop the medication or if the oncologist stops it, the heart function can improve. So we at Boulder Heart work very closely with our oncology colleagues at Rocky Mountain Cancer Center we get echoes on folks, we try to make sure they're on the right medications, get close follow-up. But so the short answer is it depends on what the chemotherapy was, and that's as specific as I could get with that question.
Talk about the benefits of low-dose aspirin if you're over 65.
I'm going to go to that side. So was it 6 months ago or something, a big article came out in the New York Times about, basically, I think it was interpreted by a lot of people to say nobody needs aspirin anymore. So that is not true. A lot of people still benefit from aspirin, but aspirin does have a bleeding risk associated with it because it's what we call an antiplatelet drug. So it makes the platelets in your blood slipperier, so they're less likely to stick together and form a clot. So we used to say, hey, you're over 55, you should take an aspirin every day, it'll be great. So that's what's changed. We don't recommend aspirin for everybody over a certain age for primary prevention. But if someone has had a heart attack or a stroke, or they have a stent, or they've had a bypass surgery, they absolutely need aspirin unless there's some major hematological reason they shouldn't. And then people who have a lot of risk factors, diabetes, high blood pressure, high cholesterol, over 55, we could consider them being on an aspirin to reduce a risk of heart attack. So the message is, aspirin isn't for everyone, but it's for some certain people. So if you've been on aspirin, I would check with your doctor about whether you should continue taking it.
Thank you. We have time for just a couple more questions. And let's see. We're going to continue. Some folks are having a difficult time all of a sudden with the YouTube, but there are those who are watching on other outlets. So let's take a couple more questions, and then we'll wrap up tonight's lecture. Let's see. I've heard of risks of statins putting one into diabetes. What do you suggest as an alternative if trying to lower LDL has not worked?
That is, so statins can raise blood sugar a little bit. That is true. It doesn't happen in everyone. And if someone didn't have diabetes before, it's very unlikely that they would develop diabetes. So it is definitely something we think about when prescribing statins. My general philosophy is statins are such an excellent class of medications for reducing the risk of heart attack and stroke that their benefit outweighs this potential for the blood sugar to go up a little bit. Having said that, we follow blood work. I mean, if I start someone on a statin in 3 months, we're going to check their cholesterol, we're going to check their liver and their blood sugar and their kidneys. So we would follow for that. So it's a good question, but it is not a factor about statins that have impeded the medical community from prescribing them, because the risk-benefit ratio is very favorable. I like to say that statins are to cardiovascular disease like penicillin was to infectious disease. It's basically revolutionized, what we do. People are legitimately having fewer heart attacks, despite my numbers in the beginning. Things are actually getting a little bit better.